Dr. Karthik and Dr. Akhil, all the best.
Oh, thank you, sir.
Thank you, sir.
Yes, sir. I think it is 8 o'clock, few seconds to 8 o'clock. Good evening, friends. It's a pleasure to host PG Clinics Friday after Friday with all your support. Now we have most eminent faculty for us today joining, Professor Patta Radhakrishna sir from Chennai. We have Professor Dinesh sir, head of the department from KMC Manipal. We have Professor Babita ma'am from Government Medical College, Tirunelveli. Welcome to all the invited faculty. And we have our eminent panel faculty. We have Dr. Rajgopal sir, Dr. Srinivasan sir, Dr. Hitesh Andaria sir, and others we are joining. I think Dr. Khanna sir has excused himself to join today. Friends, we have two presentations. One is kindly contributed by Dr. Rajgopal sir, which is a right-sided abdominal mass. The other one is the case contributed by Dr. Hitesh Andaria sir from LG Hospital, Ahmedabad. So we'll have the inguinal scrotal swelling case first. Dr. Karthik Vanani, can you introduce yourself, your unit chief, and start your presentation? Faculty, please take over. Good luck, both the students.
I think you can rotate your screen. You can rotate your screen on mobile. It will be look better. Yes. 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 Thank you. Carry on.
Okay. Good evening, sir. I am Dr. Karthik Vanani, second year surgical resident from LG Hospital, Ahmedabad. My mentor is Dr. Hitesh Andaria, sir. I am presenting a case of inguinal scrotal swelling. My patient is Mr. X, 25-year-old male patient who is resident of Ahmedabad and who is a truck loader by occupation. He presented to our hospital with chief complaint of swelling in left groin region for 2 years and pain in left groin regions for last 6 months. Patient was relatively asymptomatic 2 years back. Then he noticed a swelling in left groin region while showering, insidious and gradually increasing. Swelling increases on coughing, straining. Initially, when it was just noticeable, it used to disappear on its own on lying down. But since 1.5 years, it reduces after some time on lying down, or it has to be reduced manually by the patient. Initially, it was reaching up to the root of scrotum, but since last 1 year, the swelling is reaching up to the bottom of scrotum. It is associated with pain for last 6 months, which is of dragging type, and more after every day's work. Patient has no complaint of constipation or chronic cough or straining at micturition. Patient has no history of sudden onset of pain or abdominal distension or vomiting. Patient has no comorbidities like diabetes, hypertension, or COPD. Patient has no past operative history or no history of previous hospitalization. Personal history: patient consumes mixed diet, has adequate appetite with regular bowel and bladder rapids, with addiction of BD smoking since last 3 years. Patient has no significant family history. Based on my history, my summary of my history is a 25-year-old male patient who is a truck loader, BD smoker, presenting with left inguinal scrotal swelling, which appears on straining and disappears on lying down after some time, or has to be reduced manually. General examination. I have examined my patient with adequate exposure with consent.
Wait.
Yes.
Yes, sir.
Go back to your first slide, Kathy. The examiners would like to first discuss the history part of it.
Yes, sir.
Faculty, please take over.
So, yeah, I think Madam wants to probably.
Yes, sir. He mentioned, you go to the next slide. You told that the pain in the left groin region for past 6 months only.
Yes, ma'am.
What do you think the pain is due to?
The pain is probably due to the content of the swelling, which can be omentum or bowel, which causes dragging type of pain, which is not constant
dragging
as
type
per
of pain?
patient history.
Something?
Like something is pulling, dragging type of
Have
pain
you
in
asked
groin.
about the detail about the pain?
Sorry, ma'am.
Have you elaborated the pain, history of pain when it occurs? Whether any
Yes, ma'am.
aggravating or relieving factors like that? What is the type of pain like that?
According to patient history, the pain is more after every day's work. Means like a prolonged standing after a job. Pain is more during the evening or night.
Evening and night.
After every
Not
day.
after. What is his work?
Is a truckloaded occupation which involves carrying heavy objects and loading it into a truck.
Heavy weightlifting is there.
Like,
But in your
yes,
history,
ma'am.
you didn't mention about any history of weightlifting or something. And you mentioned about history of straining and micturition. Do you ask for straining and micturition in a 25-year-old?
Ma'am, there can be a history of trauma or patient, if patient is previously hospitalized, there might some iatrogenic injury to urethra or something like that, which may cause meatal stenosis, leading to straining, developing hernia.
So
But
you are thinking of meatal stenosis or stricture urethra?
Stricture urethra, I'm sorry, stricture urethra,
Stricture urethra.
due to trauma or previous infection.
Any other history you want to elicit?
History, based on history, patient has more complaint of developing a swelling, which used to reduce on its, but now it takes some time to reduce if it at all reduces on its own, or it has to be reduced manually. So
Initially,
it points more towards
was
indirect.
spontaneously reducible. Now it only reduces manually. That's what you wanted to tell us.
Manually or after some. Yes, ma'am.
Okay. Anything else you want to add?
Ma'am, the swelling is after activities, the swelling is reaching up to the bottom of the scrotum, which
No, what you have not mentioned here. Anything extra? You may think it is
no,
missing.
sir, I'm not aware.
Go to the next slide.
Sir, I'm not aware of it.
Okay,
Yes,
we'll
ma'am.
go to the next slide. Next slide. You have mentioned about the constipation, previous one.
Yes, ma'am.
Sudden pain, distension of abdomen, vomiting. Why?
As the swelling is reaching up to the bottom of the scrotum, sometimes it may cause irreducibility and obstruction, which may present, which presents
So by asking
with
this
sudden.
history, you are ruling out the intestinal obstruction.
Yes, ma'am.
Any other positive history you want to add? Like you have added no post-operative hospitalization, isn't it?
Yes, ma'am. Yes, ma'am.
Hospitalization for what?
Hospitalization in terms of patient may have any urinary tract infection, which may eventually leading to stenosis, or past operative history, significant operative history of if
no, anything
patient
else
has
you want
operative
to add? Any surgery?
Appendicectomy, previous history of appendicectomy, which may lead to
what will happen if there is a
left
previous
side?
history of
This is on
appendicectomy?
left side. This is on left side. Your history is on left side.
Yes.
So what similar
Yes,
incision?
sir.
Nowadays, they are putting the ureteric stone by cystoscopically. Those days,
yes.
you do a ureterolithotomy. When there is a patient have a history of ureterolithotomy, the same incision will be there as for the appendicectomy. So that will cause?
Yeah. Injury to ilioinguinal nerve, leading to weakening of the muscle in lower abdomen, subsequently leading to hernia. But the chances of direct hernia are more in such cases.
Karthik, I will advise you one thing. You answer what is being asked.
Oh, okay.
But madam asked,
Sorry.
you only answer that. Otherwise, you don't carry any credit. For in general, for all students, if you are not asked any extra question, don't keep on adding. Right?
Okay, sir.
Over to you, sir.
Karthik, the
Yes, sir.
injury to ilioinguinal nerve, what will happen is, see, before it enters the canal, it gives the cutaneous branches to the skin. Okay.
Yes, sir.
So if we injure it, what will happen? The more chance of weakness of the anterior abdominal wall muscles, the chance of incisional hernia is more.
Oh, yes, sir.
So if you injure the canal, inguinal nerve, ilioinguinal nerve in the canal, what will happen?
If we injure the nerves in inguinal canal, the muscular branches are already been given. So the chances of hypoesthesia,
Yeah,
loss of sensation in
the medial side of the scrotum and the thigh.
Yes, sir.
And in the labia major. In females, okay.
Yes, sir.
Okay, Karthik, one or two questions from my side. What is this classical history which your patient has given you? He's how old is he? How old is he?
25-year-old male patient.
So what is this? Classically, you would have probably made a diagnosis at this stage. What is the
sir, most probably diagnosis is indirect inguinal hernia based on young age.
Why particularly you said indirect? Why not direct?
First factor is age, young age. So indirect hernias are more common. And
1 minute, can you get direct hernia also in younger patients?
Yes, sir. If there is a inherited disorder leading to weakness of muscle, which
not only inherent, congenitally, there may be some fibers may be missing in the Hazelback's triangle, whatever it is. So not that young people cannot get direct. More than that, anything else?
Sir, the swelling is reaching up to the bottom of scrotum, and it.
1 minute. So what is the cause of this? Why the swelling is going down up to the bottom?
So because of patency of processus vaginalis.
So that is why it is indirect. Why not direct hernia? As far as this descent is concerned. Why do you get a direct hernia and why do you get an indirect? Indirect, you gave me answer. Persistent vaginalis.
Vagina, yes.
No.
The direct hernia is due to weakness of posterior.
So what prevents? What prevents usually direct hernia entering into scrotum? Yes. What is the layer which is covering the direct hernia?
Sir, fascia transversalis.
Yes. So fascia transversalis. So by there's some defect in the fascia transversalis by birth, whatever it is, some defect, congenital absence of few fibers, that may precipitate this. So if that is the situation, tell me what precipitated your patient to get a hernia in your case? Looking at his occupation, among that constipation, straining, cough, anti-smoking, and truckload, whatever weight. So what do you think the factor might have precipitated among the big?
Sir, occupation is one of the factors. Smoking is also a contributing factor. Sir.
What is the main factor? What is the main factor?
The main factor in this case is occupation. So
You are telling it is reaching up to bottom of scrotum. Then
So,
how does occupation come as main factor?
so main factor
no,
is
sir,
what I've already told the answer sometimes. Yes,
patency of processes vaginalis.
persistent. So
Yes.
this straining at whatever weightlifting, so might have precipitated to act it more down, go down into the scrotum. Okay, whatever it is. Now, one or two question. Did you ask anytime when you lift, obviously his job, that. Did you notice any severe pain in the groin in that area?
No, sir. The complaint of the patient is more pain towards end of work, like prolonged standing.
Why I ask this question is carrying of truckload. I don't know how much lifting, 10 kg, 20 kg, 50 kg, 30 kg. That
Yes,
have also torn a few fibers. You understand? So that
yes,
also added to already a persistent sac. And yes, he's a big smoker, but not only 6 months now. Smoking is only
3 years, sir, since last 3 years.
yes. So that's all few questions from us. And lastly, urinary problem. You said sometimes the young patient, what do you suspect? One is you said some meatus stenosis or something. Anything else?
Phimosis or sexually transmitted disease leading to infection.
No. Monitoring everything. 2-3 things are different. Phimosis, meatus stenosis is different. Sexually transmitted disease, which disease? Now, of course, more efficiently treated. So it used to be common as gonococcal urethritis. See, there could be a possibility. Examiner may ask you this question.
Okay, sir.
Scrotal junction, that bulbar structures are more common, not penile structure. Okay, bulbar, multiple. So that's a young patients. Okay, it's also used to be called a honeymoon cystitis or something like that. Honeymoon. Okay, sir. That's all.
Sir, can we move to next examination?
Please, sir.
Yes, sir.
Yes.
It's not that important in hernia. Okay.
Okay. So I examined my patient with adequate exposure with consent in valid room. Patient is conscious, cooperative, well oriented to time, place, and person. I have examined my patient in supine and standing position. His vitals are temperature normal by palpatory method, pulse 80 per minute in right radial artery, regular rhythm and normal volume. Blood pressure 130 by 80 millimeter of mercury in right radial artery by auscultatory method in supine position. Respiratory rate is 16 per minute. Patient has no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. Respiratory system, bilateral air entry present. Cardiovascular system, no abnormalities detected. On examination, inspectory finding, abdomen is flat, umbilicus is centrally placed and inverted, no visible dilated veins, scar marks, sinus or fistula. Right inguinal region appears normal. In supine position, in left inguinal region, there is fullness present. On standing position, they approximately 7 by 3 centimeter size. Piriform shaped swelling in left inguinal region, extending up to base of scrotum. Skin over swelling is normal. Expansile cuff pimples present on cuffing. Scrotum on right side appears normal. Penis is centrally placed. On palpation, per abdomen soft, non-tender, no palpable organomegaly. Right inguinal region is normal. In supine position, there is 5 by 3 centimeter size piriform inguinoscrotal swelling reaching up to root of scrotum. While in standing position, there is 7 by 3 centimeter size piriform inguinoscrotal swelling reaching up to base of scrotum with regular margin. Getting above the swelling is possible. There is expansile cuff impulse. Consistency of the swelling is granular. Swelling is reducible. Deepening occlusion test is positive. Bilateral testes are palpable separately after reduction of swelling. On percussion, there is no free fluid percussed over abdomen. Bowel sounds are normal. No bowel sounds heard on auscultation or left inguinal swelling. On per rectal examination, normal anal tone, no mass or prostatomegaly. Urethral examination by palpation, there was no palpable stricture. On my Eastern examination, my diagnosis is left-sided, complete, uncomplicated, indirect inguinal omentocele.
Karthik, can you go to your
Yes, ma'am.
local examination? Local examination, I prefer that your inspection should be always in the standing position, not in the supine. And you have to describe the inguinal scrotal region first, then only the abdomen. It is not the part of the abdomen. I feel that it should be the inguinal scrotal region, inspection of the inguinal scrotal region. The inspection is only on standing.
Standing.
On supine position, you will do the examination only for the special test, that deep ring occlusion test. Well, you have mentioned only about the deep ring occlusion test. And on standing position, you have mentioned that what is the extent of the swelling?
Ma'am, on standing position, the swelling is reaching up to the base of scrotum.
What about the upper extent?
Ma'am,
extent lower limited is up to the base of the scrotum, but on the upper extent?
Ma'am, upper extent is roughly a mid-inguinal point.
At least you should be able to tell it in the palpation, no?
Yes, ma'am.
Yes.
How do you describe on palpation the higher upper extent?
Sir,
from where does it come?
On
No,
from
anatomically, from where does the swelling comes?
So swelling comes from deep inguinal ring.
So where do you expect the extent, upper extent?
Approximately 1 finger breadth above the.
No. You don't say approximately. Madam has asked you specifically palpation. So you have to mention it in relation to some bony marks. If you have not done, say I have not done or forgotten. But how will you like to do?
I will palpate pubic tubercle and anterior superior iliac spine. I will like to palpate pubic symphysis, anterior superior iliac spine, and mark the midpoint, which is a mid-inguinal point, and the deep inguinal ring is situated 1.25 centimeter.
For extent, you have to select one bony landmark. Right? And
what
from
landmark you will tell, whether anterior superior iliac spine or the pubic tubercle? Normally, for UGC, we tell that it extends from the anterior, how many centimeters from the anterior superior iliac spine,
yes,
and extends up to the root of the scrotum or the bottom of the scrotum.
Yes.
Okay.
Go to your next slide. Again, the inguinal scrotal region should be your first preference, not the abdomen. And yes, always in the standing position. Hernial examination is always on standing position. And what do you mean by margin is regular?
There is no irregularity of the margin.
Do you expect irregularity of margin in inguinal scrotal region?
No. No, ma'am.
No. When you discuss about any other surface swelling only, you can tell like that. Here you can tell well-defined margins if you wanted to tell. And your return swelling is reducible, cough impulse is seen. What do you mean by deep ring occlusion test positive?
Deep ring
occlusion test?
First, I will ask the patient to lie in supine position, then reduce the swelling and put the thumb over deep inguinal ring. Then I will ask the patient to stand up and
No.
release
First you do it in. First you ask him to stand up, or you ask him to cough. What do you do regularly?
Yes, sir.
What do you do regularly
Yes,
in OPDs and wards?
Yes, I will reduce the swelling and put thumb over deep inguinal ring, and patient ask the patient to cough. If swelling appears medial to my thumb, it is a direct inguinal hernia, which suggests
You have written this
deep ring
positive.
occlusion
What do you
test
mean
is
by this
negative.
positive?
Listen to the question. What do you mean by deep ring occlusion test positive? The simple
Positive.
question, and you are moving here and there.
Yeah. The deep ring occlusion test positive, which means after reducing the swelling, once I put my thumb over the swelling and ask the patient to cough, the swelling does not reappear, but
It's better you tell like that. On deep ring occlusion test, whether the swelling appears or doesn't appear.
does not.
Is your test
Does not
enough?
appear.
If you test that it is not coming by putting thumb, is your test enough, or will you like to continue
No.
further?
And I will like to continue the test.
What do we do?
Now I will ask the patient to stand up and release my thumb. If swelling appears, which suggests the deep ring occlusion test is positive.
Any other test you wanted to do?
Yeah,
You want to
Karthik,
do?
just now, madam told you this positive, negative, that should not give confusion. Whether it's like Trendelenburg's, similarly Berry's sign. So it's better you tell your finding rather than positive, negative. Very clear it is. On deep ring occlusion test, in the line down you have tested. Swelling is seen or not seen.
Yes.
If the swelling is seen, it is direct hernia.
Yes.
Swelling is not seen, probably it's indirect hernia. Still, you make the patient to stand. Why? Why?
So to see if swelling reappears after releasing my thumb from deep ring.
Why do you want to release your thumb when you make the patient stand? You are not going to release your thumb. This is not a Trendelenburg's operation. Okay,
Yes.
Trendelenburg's test.
Okay.
The idea is you should not miss even a femoral hernia. You understand, no? So
Yes.
you understand what I'm telling?
Yes, sir.
When you have occluded the deep ring, if patient has a cough impulse, it is direct hernia. Yes, correct. I don't deny
Yes.
that.
Yeah.
But still you make the patient to stand and cough because you may easily miss a femoral hernia. Keep it in mind. And men also can make femoral hernia.
And
Okay.
one more thing I like to add, you release, even in supine position, you release the thumb and ask him to cough. If it does not come for 2-3 cuffs, you can be having the similar problem while putting finger. There can be some adhesions at the level of neck, and it might not come even if it is direct hernia, very rarely. So better to release and check it. Once it comes immediately on first cuff, that means it is indirect hernia. Then you continue the same process with standing position.
Any other test you wanted to perform?
We can perform a Zeman test.
Why you have not mentioned about Siemens 3-finger test?
Ma'am, routinely we are not performing Zeman test.
No. Ring imagination test is not routinely done because it may cause pain to the patient. But why not the Siemens 3-finger test? Where will you keep the fingers in Siemens 3-finger test?
I will put index finger on deep inguinal ring, which is just above the mid inguinal point. The middle finger over superficial inguinal ring, just above the pubic tubercle, and ring finger 4 centimeter below and lateral to pubic tubercle at femoral opening. And as
Which
the
finger,
patient,
which hand you'll use?
the hand, I will use the hand. Means whichever side of patient I'm examining, I will use the same. Left hand. Left hand, sir.
So what do you expect? What are you expecting in this patient in a Siemens 3-finger test?
In this patient, I am expecting cuff impulse over my index finger, since the patient, the swelling is coming from deep finger.
You are told the consistency is granular. What do you mean by that?
Means because of the content is like with omentum, so it gives granular consistency on palpation. I don't know.
There's nothing
Granular
like
and
granular consistency. Okay, don't use that unnecessarily get into trouble. You want to tell it is momentum there. So don't have to say
Granular feel.
Feel.
Wise, you know, that you normally we use the word feel.
Yes. Do it.
And you told on the history patient has the swelling is not reduced spontaneously. Patient reduces it manually. How did you reduce the swelling while doing this deep ring occlusion test? What is the maneuver called?
Ma'am, the maneuver is called Texas, in which we flex the knee of the patient, adduct, and internally rotate the hip joint, which releases the muscle of abdomen, hence cause ease in reducing the swelling.
Karthik, what is the best way to get this swelling reduced? What is the best way to get this swelling reduced before examining for deep ring occlusion test? What is the best way?
Question asked is who can reduce it completely better?
So patient
Yes.
himself, as he is performing.
You can ask the patient to reduce by himself.
Don't give explanation. Tell answer. You are giving as he himself. Ask the patient to reduce.
Yes.
If patient comes to you with irreducibility, he says that for 2 days I am not getting. I was able to put it down with some maneuver. Now I am not able to put it down. Will you do Texas by yourself? And he has some pain, occasional vomiting, say for 1 hour, 1 or 2 hour vomiting. Will you try to reduce on your own?
No, sir.
Why?
Sir, during reducing, I may injure the content.
What can happen to swelling?
Injure the content. No.
If you are
what do you expect if the patient is coming with irreducibility and sir is telling there is history of vomiting, occasional abdominal pain? What is your diagnosis?
Ma'am, obstruction.
Obstructed hernia.
Obstructed hernia.
Yeah. So what can happen?
Try to reduce it.
If you do Texas, what can happen? What is that phenomenon known as? Patient may get temporarily more pain and then may feel little bit good, but after 2 hours he will have severe pain abdomen. What is that known as?
Sorry, sir, I'm not aware of.
Reduction in mass. Reduction and mass. It may reduce en mass. It may lead to perforation and then go inside, and patient may develop peritonitis.
Peritonitis. Yes.
So better not to use the word Texas, and don't attempt if patient says that for last 2 days. If he says that for last 6 months, 8 months, 1 year, I'm not able to reduce, even then you don't try to reduce, right?
So, yes, sir.
What sir was trying to tell you, the whole, you may think you have reduced and you are comfortable, but the whole thing has been reduced, but obstruction is not relieved. You understand, no?
That is called
Yes,
reduction and mass.
So 1 or 2 other questions to Karthik, because it's a hernia is a fairly straightforward case. Tell me which swellings are inguinoscrotal other than hernia. I will ask you one question. In which inguinoscrotal swelling you don't get cough impulse? Yes.
Sorry, sir. If the swelling is irreducible due
Just
to chronic,
give me
Not
a
swelling, hernia. Irreducible hernia, you say, not swelling.
irreducible. Yes, sir. Irreducible.
give me a DD for inguinoscrotal swelling. First is hernia. Over. Next.
Uh,
Yes.
thickening of cord structure due to infection.
Like what? Thickening of cord structure due to infection, little vague terms you will not accept in surgery. What do you want to tell? Tubercular epidermolysis, is it? With the thickened mass in the it will not be like classical inguinoscrotal. It's inguinoscrotal. Can you think of anything else?
There is a content
Yes.
other than bowel and omentum.
Yes. So, come on. So you should know diffuse lipoma of the cord. It's a separate entity.
Yeah.
You get sometimes a big lipoma there. Can you get one hydrocele also? You can get
Yes.
what type of hydrocele
Okay.
they are called as?
Uh,
It's not truly hydrocele of the cord. There's something else. Somebody has put as hydrocele of the cord. That's fine. But in addition, hydrocele of the cord means probably someone should say encysted hydrocele. Like
and his ancestor diabetes.
but more importantly, what is infantile hydrocele? Can you tell me that? Don't tell me it's in infants. That's why I asked you this question.
Yes.
You know the type. Okay, I think we are debating, but you know that the sac is not only in the tunica vaginalis patent in the scrotum, but it is up to the deep ring.
The deep ring.
No.
Yes. Ma'am.
Sometimes a patient with ascites, right? The same way congenital hydrocele appears, the patient will have ascites and you may feel a similar fluid content there up to deep ring and scrotum. It is reaching, but usually it will be bilateral, usually.
So these are some of the setter questions for a DD. You know, they ask you inguinoscrotal in the standing position. Varicocele is another where it goes into the scrotum also. But these are diffuse lipoma of the cord. Even in fact, a soft tissue tumor of the cord, leiomyosarcoma has been described in the cord. It can go from inguinal region into the scrotum, and of course, infantile hydrocele.
Large hydrocele.
Yes, sir.
So these are some of the DD. Yeah, please go ahead.
Okay, tell your diagnosis, Karthik.
Based on my history and examination, my diagnosis is left-sided, complete, uncomplicated, indirect inguinal omentosele.
No, you will tell that indirect inguinal hernia. The content is the omentosele. What do you mean by omentosele? The content is the omentosele. So your vision should be left-sided, complete, uncomplicated, indirect inguinal hernia with the
Omentum as a content.
Be the omentosele.
Oment.
How do you want to proceed with this patient?
I will explain the patient about the severity and the complication it may lead, and eventually
What
the surgical
complication
option.
it may lead if this patient is left untreated?
He may develop obstruction in future or strangulation.
Indirect hernia more prone for obstruction or direct hernia prone for obstruction?
Indirect hernia, ma'am. As
okay.
So I will ask the patient. The surgery is the treatment of choice, and you should go for it. And I will.
You wanted to do any investigation?
I will do the routine blood investigation required for the surgery and ultrasonography.
For what?
For what?
To check the content.
This young patient, for what reasons you want ultrasound? What is the purpose of getting ultrasound abdomen done in hernia? Your answer should be, it is not to confirm the diagnosis, but it is to rule out any cause of increased intra-abdominal pressure. Right?
Okay.
Usually we'll do ultrasonogram abdomen. If it is the patient is the old patient, what will you expect in the ultrasonogram abdomen?
Prostatomegaly, will detect the prostatomegaly on ultrasound.
So how will you judge?
How will
that
you assess the
prostate
prostatomegaly?
Based on the patient will have complaints such as nocturia.
No, in ultrasonogram.
Ultra. Full-blooded sonography, ma'am, and check the pre-word and post-word volume.
What else? Which suggests in prostate, the size does not matter, right? Size may be more and he may not have symptoms. Size may be less and he may be having obstruction. So what things you will look for in ultrasound abdomen to suggest that this patient has some prostatic problem or hyperplasia?
Residual volume after.
Okay, that is one. Anything else before that? That will come at the end of first sonography. What else?
Yeah. Retention of urine.
No. He is not having retention. Otherwise, he will present with retention.
Retention. Okay.
So what do you look on ultrasound, or what radiologist looks to say that this prostate is causing obstruction to urinary system?
Intravesical extension of prostate.
Okay, that is one. I am telling you the obstruction. Back pressure changes. What are they?
Okay, sir. Yes, sir. Bilateral hydroureter.
Bladder wall thickening, you say, right? Hydroureter, hydronephrosis, it is late phenomenon, right? So first is bladder wall thickening.
Clinically, what are the symptoms the patient may have? The patient is having a prostatomegaly with bladder outlet obstruction.
If urinary retention, as patient is in bladder outlet obstruction.
What are the history you'll ask? Not only urinary retention. Is the patient, all the patient will present with urinary retention?
A patient may have
what are the symptoms you'll ask?
Nocturia, frequency, stream of urine, hesitancy. Yes.
You think the bladder has a overhead tank and there is an outflow obstruction. So patient wants initially there will be a straining that there will be a difficulty in initiation of the micturition that you called as the hesitancy. Because of this obstruction, the bladder cannot be emptied properly. So there will be increased frequency. Then because of this residual volume, the patient has an urgency to go immediately. If it is not go immediately, there will be a dribbling of urine, precipitancy. So you should ask for hesitancy, frequency, urgency, and precipitancy. If it's an old patient, any other examination you wanted to perform?
Karthik,
apart from prostate?
Madam, one question. Karthik, in your patient, why ultrasound is used? Why you should do and what information it can give rise to? Why should you do ultrasound in your patient? Tell me. Hernia is a clinical diagnosis. Please remember.
Yeah. Yes.
We don't do any other investigations unless there are specified reasons. You can tell ultrasound is done for one, whatever insurance purposes at all. Any other reason in this patient? Can hernia be bilateral? Incidence can be. So can you pick up a occult hernia by ultrasound? Very nicely can make out. You understand? Early buborrhea.
Yes.
Very early buborrhea, where just an impulse is there near the deep ring. Okay.
Okay, sir.
Which earlier professors used to use that finger imagination test. One of the advantages was this, which is of course nowadays is not done. Putting your finger deep into the deep ring, near the deep ring, and ask the patient to cough. Pick up it very early. So today, ultrasound is another excellent medium for picking up that. Okay. Just for completion's sake only, in which patient you do CT scan, if you want to do for a hernia. I'm only talking about hernia. Don't tell me abdominal tumor and all that thing.
Yes.
So this hernia is a clinical diagnosis. You don't do any other investigation other than the fitness. You can do a chest X-ray, BD stroker. Ultrasound is done also to look for the other side, correct? Then
Yes, sir.
what indication when you want to do CT scan? Not that it could be in every case, but yes. Yeah.
Sir, in recurrent cases,
Current. Why? What additional information you give? So when
How
the
many recurrent hernias have you seen and CT scan advised?
So imagine a very large hernias, giant hernias where the contents can be bladder. You heard of sliding hernia?
yes,
What is sliding
yes.
hernia? What is sliding?
So sliding hernia is a in which posterior wall is formed not only by the peritoneum but the content of the
Whole
abdominal
things,
cavity.
you know, so
What can be the contents?
The content can be bladder, sigmoid colon on left side, cecum, appendix on right side.
where
And
the very, very large defects sometimes, you know, posterior wall defect, Gilbert's type 4, they used to tell earlier, pantaloons, big hernias. So where, you know, anatomy is distorted. So sometimes, you know, whole bladder can, not that ultrasound is also quite good to pick up, but then anatomy is distorted. So that is the time better you do CT scan if necessary, MRI also. Okay, right, sir?
Yes, sir.
Karthik, any pelvic hernia, not inguinal only, can be diagnosed by CT scan, which is not having any swelling. Do you know? Patient may present to you with pain or sometimes obstruction, and it is diagnosed on CT scan.
Sir, I'm not aware of.
Obturator hernia.
What are the hernias
Okay,
you can get it in that region?
Sometimes
Sarah answered.
yes.
Actually.
Many
Even
times
if the patient has pain, but you are not able to elicit the cough impulse properly, in that case also you can have a
yes.
CT or a, especially in a sportsman. In that
Obese
case, you
person.
can identify that. What is Richter's hernia?
It is a hernia with the part of the bowel is the content, not the entire bowel. Only the part of the bowel wall is content.
What is the significance of it?
As only the part of the bowel wall is content, the initial presenting symptom is diarrhea. But if more than half of the lumen is occluded or involved, it may lead to
You may miss
constipation.
the strangulation in the earlier period. Even it is
Yes, ma'am.
strangulated, you may miss the strangulation. What is Madel's
Yes, ma'am.
hernia?
Sorry,
Madel's.
it is a W-shaped hernia with the strangulated portion is within the abdominal cavity.
Within the peritoneal
So,
cavity.
within
Again,
the-
you may
within
miss
the
if it
peritoneum.
is not you on exploration. If you doesn't explore it properly, you may miss the strangulated
Strangulation.
portion.
Yes,
Isn't
ma'am.
it?
Yes, ma'am.
You tell me a few differences between direct and indirect hernia.
The means presenting symptoms, if the hernia is reducing on its own and lying down, it is a direct inguinal hernia. The indirect hernia is it reduces after some time, or it has to be reduced manually.
Even indirect hernia reduces on the earlier stage,
Yes, ma'am.
spontaneously.
Yes.
Any other differences?
Presenting age,
Age,
the direct
one
hernia.
age, then
Causative factors.
what is the relationship of the sac with the cord? What
In
is
case
the
of
course of
direct,
the hernia?
in case of direct inguinal hernia, the sac is posteromedial in relation to cord structures, while in indirect inguinal hernia, the sac is anterolateral in relation to cord structures.
Okay.
Then the direct inguinal hernia is medial to inferior epigastric pulsations, while indirect inguinal hernia is lateral to inferior epigastric pulsation coming from deep inguinal region.
Okay.
Uh,
Then what is the cause? How the indirect hernia comes? So how the direct hernia comes?
The direct hernia comes through weakening in posterior wall of inguinal canal through Hasselbank's triangle, while indirect hernia comes through deep inguinal ring and
Deep inguinal ring, then
passes along the cord structure and through superficial
cord
inguinal
structure.
ring.
That comes through the
Through
deep ring, traverses the inguinal canal, comes out through the superficial ring.
Superficial inguinal
Direct hernia, it comes out through the Hasselback's triangle and then the superficial ring. That's why it doesn't reach us up to the bottom of this scrotum. So tell me the boundary of the Hasselback's triangle.
Yes. Medial, it is bounded by lateral border of rectus abdominis, laterally by inferior epigastric vessel, and below by medial half of inguinal ligament.
Okay, what treatment you wanted to offer this patient?
As the patient is young, I will explain the patient about open and laparoscopic repair.
And or what?
Which is ideal in this?
I would suggest patient to go for open inguinal herniaplasty.
Why?
As I'm
So you don't say I would suggest. I would do open hernioplasty. But
yes,
you have to explain both the things to patient. As patient is young, you have to explain both the things.
Yes, sir.
What do you mean by hernioplasty? What is the method you will do?
Lichtenstein tension-free mesh repair.
What is it?
I will reduce the means put a mesh or to strengthen the inguinal canal.
Strengthen the inguinal canal?
Means first I will
part of
do
the inguinal
herniatomy.
Yes, first you do the
Herniatomy, reduce the content, and
what is herniatomy?
Herniatomy is opening of the hernial sac. Then I will
That's all.
reduce the swelling and then transfix.
What do you call that? High ligation and transfixation of the. How will you know this high ligation?
It is done at the level of deep inguinal.
So how do you know?
I will
inguinal canal dissecting the sac. How can you know that you have reached that level of deep ring or neck of the sac? What contents will suggest that you have reached adequate space?
Visibility of preperitoneal fat.
Yes, and you can also see the inferior epigastric vessels medially in this case.
Yes.
Karthik, suppose patient says that I have some bad memories for mesh plasty. I would want mesh to be kept. What else can you offer in this patient? In this patient,
as the patient is young, I will offer
young and indirect hernia. So what can you offer?
I will offer him shoulders repair. Sir.
Okay, what is that?
It is
modified shoulders
6 level.
But you call it shoulders, right? That's fine. So what do you do in shoulders repair?
Means approximation of conjoint tendon.
Oh.
Six layer repairs.
No. What
Double
is the
breasted.
main layer in shoulders repair where you depend on?
Fascia transversal.
Okay, here there is the fascia transversus is not weak. So what will you do? This is indirect inguinal hernia. The only deep ring is widened.
But,
So what will you do?
so little's repair to
No, okay.
No, what is the
Hernia
actual component you wanted to do in the shoulders in this patient?
little's repair, you do it only in congenital hernia.
oh,
You cut open the fascia transversalis at the medial angle of deep ring, and then you double twisting
Double breast.
of the fascia transversalis with polypropylene suture 10, right?
yes.
Double breasting, the way you look at your blazer, which is like this, not like your shirt, like this, it is like this, right?
Yeah.
Okay.
And you told Lichtenstein tension free. Why you told tension free?
As we are putting mesh.
Okay.
So
Now, initial days
Yes,
they
sir, yes.
used to do a Besnis, that is
Bessini.
conjoined tendon is sutured to the inguinal ligament. Then
Inguinal
they will
ligament.
keep the onlay mesh. But after the Lichtenstein modification, they won't do the approximation of
Okay.
conjoined tendon with the inguinal ligament. They will just keep the mesh in the posterior wall of the inguinal canal to strengthen it. So there is no
So
tension
tension.
of approximating
Okay.
the conjoined tendon. So patient will have a less pain free.
Oh.
Sir,
Okay.
okay, you tell me the complications of hernioplasty.
Immediate complication of injuring the blood vessel.
What blood vessel?
Inferior epigastric vessel.
Okay.
If
Where will you purposefully cut the inferior epigastric? Okay, thank you, Karthik. You read about the complication. As Sir told, it is getting late for the next case. We'll proceed on with the next case. Congratulations on your
Karthik, injuring
Yes,
the inferior epigastric is not a complication. It's not a
Okay.
complication.
Yes. Thank you.
Karthik, I'll advise two things. One is you, even if you don't know, you try to attempt that question. You don't do that. If you are not sure, or if you are not even 50% sure, say that I don't know. That will make your life easier in exam. This is my frank advice. And second thing, whatever you are asked, be specific in your answering to that question. Don't move around and come to that question.
That's more important.
These two things are needed. Otherwise, you have performed well as far as clinical aspect is concerned.
Thank you, sir.
Sir, Dalvi sir, please ask your question, sir. Good evening, sir.
No, I have only some suggestions for this candidate. He
Yes,
looks
sir.
to be good, but don't only read theory and then get your findings to, omentocele, granular. These are not things which are actually expected out of you. And madam, I think clearly indicated to you that these things cannot be examined that way.
Yes.
Second is, if you are presenting a case of inguinal hernia, you have to know definition of herniotomy, herniorrhaphy, and hernioplasty. If at all you cannot define them, you are going to be in a big problem. Do not use word like granular. Instead, rely on reduction with a gurgle or without gurgle. auscultate the patient. The contents of intestine will tell you that there are peristalsis, and you can confidently say that this is an enterocele rather than an omentocele.
Yes, sir.
Examiners will always ask you about Bassinis and shouldices, though it's almost gone now, but still. All other repairs, you talked of, which repair did you talk of?
Lichtenstein.
No, McVay, I think. What did he talk?
Shoulders.
No,
Shoulders.
no. He talked of one more repair. Anyway, you talk of anything apart from Bassinis, shouldices, and Lichtenstein, you will be questioned for sure. And if you are questioned on that, you are going to be in trouble. Your presentation was okay. Your questions were okay. Answers, whatever you knew. And I think will go with Dr. Andaria. If you do not know something, do not try to over answer something to satisfy examiner. Much better to say, I don't know, and get out of the situation. Thank you so much.
Okay. Thank you, sir.
Thank you, doctor. Faculty, we move on to the next case. Kana, you can unshare your screen now, Karthi. You did well. You can stay back for the second case. Akhil, you can start your presentation, Akhil. Akhil, go to the first slide.
Yes, sir. Is it visible, sir?
Good luck to you, ma. You are good to go.
Yes.
Good evening, everyone. Today I'll be presenting a case of mass abdomen under guidance of Dr. Dinesh BV, HOD, Surgery Department, KMC Manipal, and Dr. Rajgopal Shunai, Professor, General Surgery Department of KMC Manipal. Here is a 60-year-old gentleman, farmer by occupation, hailing from Davangere, is an nilpri morbid presented to GEC OPD with complaints of pain abdomen for 3 months. Pain abdomen is insidious in onset in the right lower abdomen, intermittent colicky type, and non-radiating. No aggravating or relieving factors. Pain abdomen is not associated with abdominal distension or bleeding PR. Patient also gives history of weight loss of 12 kgs in the last year. There is no history of vomiting or constipation or loss of appetite, and there is no history of fever. Coming to past history, patient is nilpri morbid. There is no history of tuberculosis. There is no history of similar episodes in the past. No history of previous hospital admission. And family history is nothing significant. Personal history, patient consumes a mixed diet, and bowel and bladder movements are regular, adequate sleep and appetite, and there are no habits.
Before going to the examination, we'll have some questions in the. You go to your first slide. Complaints of pain abdomen for 3 months. And you have mentioned it is in the right lower quadrant. If the patient complains of pain in the right lower quadrant, what are the things you come into your mind? What does your think of?
In acute, we will think of appendicitis.
Okay. Now the patient gives a complaint of 3 months.
3 months.
Then?
Because of age, we can consider malignancy, right-sided colon malignancy.
Okay.
We can consider the ileocecal tuberculosis.
Okay.
Inflammatory bowel disease can also present.
Okay. How will you rule out all these things by history? If you think of colon malignancy, what are the history you'll ask?
Malignancy, right-sided malignancies are the usually not with much symptoms, but patient can complain of anorexia and bleeding PR,
Bleeding PR? Bleeding PR is more common in left-sided or right-sided malignancy?
Right-sided.
Right-sided, you can detect only through the occult blood, not pure. Anything else apart from this?
Patient can have obstruction features now.
Obstruction is also more common in the
Left side now.
left side. Then what else? Patient will have anorexia, malaise, or weakness. But you
Yes.
here there is no history of loss of appetite, but there is a weight loss. What do you
Yes,
think?
We can't rule out, ma'am, but there's a possibility of malignancy.
No, you told that there is a weight loss of 12 kgs in 1 year,
Yes,
but
ma'am.
he gives history of pain abdomen only for past 3 months, and there is no loss of appetite.
Yes, ma'am.
How will you confirm for your weight loss?
Ma'am, if malignancy, if you're suspecting malignancy, it can be cancer cachexia, ma'am.
Then that should be a loss of appetite should be there, no? Anything else? What are the causes of weight loss other than cancer cachexia?
Malabsorption, ma'am.
Okay. Then
Anemia, ma'am.
anemia will cause weight loss. Okay. Then you asked for vomiting. Why do you ask for vomiting in a patient complains of pain in the right lower abdomen?
Ma'am, part of Murphy's triad, ma'am, vomiting and fever. And
you suspected even appendicitis.
Inflammatory pathology, ma'am. And
Any inflammatory pathology. Okay. You think you may have any inflammation. Okay. Next slide. And no positive past history or family history. Sir? Sir?
Madam? Yes,
No,
madam.
Srinivasan sir is not there, sir.
Madam?
Since
Dr. Srinivasan sir is not there.
Madam, I think his problem is with the internet, madam. He's not able to
Okay,
come.
sir.
Anyway,
Okay,
Please
then
go ahead, ma'am.
we'll continue.
Just
Okay,
Yes,
sir.
madam.
Okay.
Yes, madam. Yes, madam.
since
Okay.
Akhil,
Okay, doctor, continue.
Akhil is our student, I did not ask much question, but just want to.
Okay, sir.
Sir, Abhay Dalvi sir, I think has some questions, sir.
No question. Nahi. If other examiner is not there, I will take over.
Yes, sir. Please, sir. Sir.
Sure, sir. Sure,
Please
sir.
take over, sir.
Sure, sir.
Yeah. So, what's the boy's name? Akhil.
Akhil.
See, when patient comes to you with pain is the only symptom and weight loss, correct?
yes, sir.
Right iliac fossa. Why
Yes, sir.
are you only sticking to GI tract? I know patient is a male. Tell me what other organs can exist in an abnormal position giving rise to these symptoms.
So the undescended testis, sir.
Undescended testis, okay. As a very lenient examiner, I'll still give it to you.
No, you told abdominal pain and weight loss. You think of combine these two.
See, when you're telling me weight loss, you're moving towards malignancy. I know that. Abdominal colicky pain. Does it occur in a urinary tract?
Yes, sir. Ureteric colic.
can it happen in a horseshoe kidney or a ectopic kidney?
Yes, sir.
Why in your history I don't find anything? So next time, when you have a patient where you cannot elicit history which is indeterminate, you got to look at what are the organs possible which can give rise to this sort of problem. Okay?
Okay.
Go ahead. Go ahead.
If I can come in. Good evening, Dr. Shana, sir. Nice to see you.
Good evening.
Akhil,
Yes, sir.
now the significant history I find in your presentation is that it's got a palpable mass, or rather, so it is a mass in the pain in the right iliac fossa, a matter of fact, and a 60-year-old gentleman and significant weight loss. They're putting these three together, you are thinking in terms of a malignancy. There are certain other conditions in the right iliac fossa we can think of, which includes, as you're saying, and that tuberculosis and Crohn's disease. So, I mean, it's very easy to say no history of tuberculosis, but you need to say a little more in detail, about symptoms of tuberculosis, if you can tell us, and also symptoms suggestive of inflammatory bowel disease, because that's also one of your different diagnoses. What are the symptoms of, because you need to give some history to sort of negative history to rule out those conditions. Mitosis is agreed upon, but just give a little more emphasis on the other different diagnoses and how you rule them out historically.
So tuberculosis, no history of abdominal distension, sir. No history of any obstructive features, sir. And no history of evening rise of temperature, and no history of any close contact persons with tuberculosis.
Okay.
And
okay.
No history of any drug intake, prolonged duration drug intake.
That is no history of anti-tuberculosis treatment.
Yes, sir.
Okay. Regarding inflammatory bowel disease?
No history of any alternating bowel habits, sir. And no history of bleeding PR, sir.
Okay.
I think he has no clue at the end of history, because the patient has not given me any history of symptoms which can point to any other disease. So I think, Akhil, we will go ahead with symptoms: colicky abdominal pain, non-obstructive in the right iliac fossa, which points to somewhere in the colon, somewhere in the ileocecal region, or whatever it is. Go ahead with examination.
Yes. In general physical examination, patient is moderately built and nourished. Patient has height about 163 centimeters and weight is 53 kgs and BMI of 20 kg per meter square. And Karnofsky performance score is 90.
1 minute. Wait here. What is Karnofsky score?
So it is used to assess the performance status of the patient.
In which patients?
So it can be used both in benign and malignant conditions.
In which benign conditions this score is used? You don't know, right? Yeah. So it has become a habit of talking about Karnofsky score and some other score which is done in malignancy only, but it has become a habit of including it. Please do not do that. According to me, the other examiners may agree with you, but do not do it.
Yes,
with
sir.
me.
I agree with you, sir.
Yeah. Because then you are telling me that you are hell-bent on telling me that it is malignancy.
Yes, sir.
Okay. Some examiners like me will pounce on. I don't even know what is the score. Let me tell you very frankly, but I know it is a malignancy score. So if you're going to lead me right in the general examination that it is malignancy, most of the examiners will come very heavily against you.
Okay.
Okay. Yeah. Go ahead.
Patient is having pallidus and there is no icterus cyanosis, clubbing or generalized lymphadenopathy or pedal edema. Vitals, pulse rate is of 84 beats per minute in adequate volume and regular rhythm. And the blood pressure is 110/70 millimeters of mercury in the right brachial artery in supine position. Respiratory rate is 18 per minute and patient is afebrile during examination. Coming to abdominal examination, patient is examined after the informed consent in well-lit room in supine position. On inspection, abdomen is flat, umbilicus is central and inverted. Corresponding quadrants moves with respiration and no visible peristalsis or pulsations noted. No expansile cough impulse at the hernial orifices. No fullness noted in flanks and external genitalia is normal. Coming to palpation, abdomen is soft and tenderness noted in the right iliac fossa. There is no local rise of temperature, no guarding or rigidity. The solitary mass palpable measuring 6 into 4 centimeters, vertical and horizontal in right iliac fossa, nodular surface, firm in consistency and irregular margins. Lower margin is palpable and restricted mobility. Plane of the swelling is intra-abdominal, likely intraperitoneal, and there is no palpable organomegaly and external genitalia is normal. Coming to percussion, mass is dull to percuss and liver span is 12 centimeters in mid-clavicular line and there is no free fluid in the abdomen. Auscultation, bowel sounds are normal. On digital rectal examination, there is no tenderness or normal fecal staining is present. No palpable growth and no left supraclavicular lymph nodes are palpable and systemic examination within normal limits.
Go to your inspection. You told corresponding quadrants moves with respiration. What do you mean by that?
Ma'am, right upper quadrant and left upper quadrant both moves more with respiration because they are proximity.
That you can tell all the quadrants moves equally with respiration. That will be more ideal, no?
Yes, ma'am.
I think, madam, he is right. Corresponding quadrants, because the upper quadrants move little more, the lower quadrants move less. So this is generally well accepted.
Okay, sir.
In general, it is accepted, sir, madam. Because lower will move lesser.
And yes, sir.
No, Hitesh, I will go with her.
Okay,
is
sir.
this sentence necessary?
Actually not, but if they are mentioning, it is better not to mention.
We will give them the leeway. That is not an issue. But
Yes,
they
sir.
should know. So the question to the candidate is, why
Yes,
did
sir.
you talk of corresponding quadrants moving with respiration? He should understand what he's talking.
Yes, yes.
So tell us, Akhil.
So
Is it just because it is given in some book that you're talking?
So it
Give
is
me
more
reasons.
relevant in upper abdomen symptomatology, sir, where if any inflammatory pathology is there, the movement will be reduced comparatively, sir.
So it has to be inflammatory pathology. You agree to that?
Yes, sir.
Then why in this patient? Just to complete the theory. I'm asking you. See, the thing is, the examiner has to know why
Yes,
you're doing a particular thing or why you're talking of a particular thing.
yes, sir.
Okay. So when you know it is inflammatory condition, peritonitis, talking of corresponding quadrants does not hold water.
Yes, sir.
Go ahead.
Agreed,
Go ahead.
sir.
Go ahead.
And you are not going to get any inflammatory condition in your exam.
Yes.
Yes, sir.
Okay, going to your palpation. This in the confined to the right iliac fossa.
No, ma'am, it's involving lumbar and hypogastric regions also.
Akhil, one suggestion, don't get down. Keep your tone as before. Continue with the same tone.
Yes,
Yeah.
sir.
And present nicely. Go ahead.
Yes, sir.
So you should mention it that it has been extended into hypogastric and lumbar region.
Yes, ma'am.
Are you sure it is a nodular surface?
Yes, ma'am. On palpation, it felt nodular.
Nodular. If you say nodular, what are the differential diagnoses come to your mind?
Madam, I think let him complete the examination and then
He has completed, sir.
Yeah. Oh, okay.
He has completed and he has come to the end of your diagnosis, sir. Till diagnosis is completed, sir.
Okay. Go ahead. Go ahead.
Ma'am, right-sided colon malignancy, cecal malignancy, ma'am. Lymph nodal mass, ma'am.
Okay, more in favor of a lymph nodal mass if you say as a nodular surface.
Yes,
and you are told the plane of the swelling is intra-abdominal and intraperitoneal. Are you sure that it is intra-abdominal and intraperitoneal?
Intra-abdominal, I'm sure, ma'am, but likely intraperitoneal.
Why are you telling it is intraperitoneal?
Ma'am, nodular consistency and
no, your consistency doesn't tell surface or consistency doesn't tells you whether it is the intraperitoneal or a retroperitoneal, isn't it?
Lateral position swelling is falling forward, ma'am, falling to sideways.
The swelling falls forward.
Yes, ma'am.
Okay. Okay, proceed. Sir?
Yeah, Akhil, what is your diagnosis now and what is the different diagnosis? After clinical exam, you have anything more other than palpation?
Yeah, yes. My probable diagnosis is a right-sided colon malignancy, sir. And differential diagnosis is ileocecal tuberculosis and lymph nodal mass.
So, on basis of clinical findings, what are all the things that are pointing towards that? So, you call it right colon malignancy because of this, this, and this. And what are those?
So the age is a relating factor for the colon malignancy, sir. And long history of 3 months and weight loss and anemia.
Now, was he anemic clinically?
Yes, sir.
Okay.
Firm mass, firm nodular mass in right ilia fossa.
Right. And now the different diagnosis of ileocecal tuberculosis by and lymph nodal mass by, and you know, how did you rule them out clinically after palpation?
So yeah, ileocecal tuberculosis can present at any age, but it can have any obstructive, more obstructive features compared to right-sided colon malignancy. And
what is the usual location of a mass in ileocecal tuberculosis and why?
So it will be higher up in towards lumbar region, sir. And
why is it so?
So because of pulled up cecum in hyperplastic variant, there will be cicatrization and there will be pulled up cecum.
So this mass is not in the right upper quadrant; it's in the right lower quadrant, right?
Yes, sir.
So there's 1 point against ileocecal tuberculosis. Anything else? Yeah, abdominal tuberculosis can have many other things.
No abdominal distension and
right. Okay. Now, why it's not lymph nodal mass? You said on palpation it is nodular.
Yes.
Why can't it be lymph nodal mass? In other words, how common is lymph nodal mass in that area? And how many have you seen?
It's not much common, sir.
Yeah. It is not much common, but actually.
But as patient is not having much of GI symptoms, I have considered it as a differential, sir. And palpation, there is a nodular mass.
Yeah, see, lymph nodal masses will not have any GI symptoms, right? And secondly, lymph nodal mass can very well occur in this age group of 60. Lymph nodal mass can very well have loss of weight of 12 kg. So actually, many of the things do fit in. So actually, when you come to a differential diagnosis, the lymph nodal mass should come above ileocecal tuberculosis because many features fit in. But why you will consider lymph nodal mass second diagnosis? Because it's not a very common thing.
Yes.
Between the right colon malignancy and the lymph nodal mass is little less common. So I would rather present this as a right colon mass for whatever history and clinical examination, and lymph nodal mass is the second diagnosis, but I'll also keep ileocecal tuberculosis. Now, if it is an appendicular pathology, what could that be? If it is an appendicular pathology, which is not an acute appendicitis, anything else you can think of?
Appendicular neoplasm, sir.
Yeah, like what?
Neuroendocrine tumors.
Neuroendocrine tumor, that can be a different diagnosis, but that's pretty rare. A little more common
things.
which is palpable.
Mucinous neoplasm.
Yeah, what is it? In other words, in common terminology. Have you seen any in common terminology? What is that? Which in
palpable
case,
appendix, round at enlarged, palpable.
in case if it gets
mucocele of appendix.
Yeah. Mucocele of appendix is a possibility. Right. So with this differential diagnosis, how will you proceed? What next?
Akhil,
Abhital, would like to come in, sir, comment on the.
Yeah, Akhil, I just like to butt in. This lymph nodal mass, what could be the cause of lymph nodes? Just lymph nodes here as a differential?
So it can be either the mesenteric lymph node secondary to ileocecal tuberculosis, or it can be external iliac group of lymph nodes, or the.
No, I mean, why external iliac lymph nodes due to what? And ileocecal tuberculosis, you've kept it as a you said it's hyperplastic type, right?
Yes, sir.
So the lymph nodes are usually not that large to be palpable. Usually, the lump of the ileocecal tuberculosis is more palpable. So what could be the cause of this lymph nodes per se?
In this age group and with this systemic history. But you should keep talking, Akhil, like the previous candidate. You can't.
I didn't get the question, sir.
No, Dr. Rajiv wants to know what could be the cause of these palpable lymph nodes. Or what could be the
What could be the draining areas of this lymph nodes? Let's come to that.
So can be benign malignancies, sir. Can be
benign malignancies.
Anal malignancies, sir.
Penile. He's selling cancer penis.
Okay, penile.
It sounded like benign.
Yeah.
For me also initially.
Yeah, penile, right.
Okay, that's fine. Let's actually, it's very uncommon to just have lymph nodes here without any symptoms of its draining areas, right?
Yes, sir.
Right.
And again, lymph nodal masses are a little more medial, towards the periumbilical, towards the center rather than towards the periphery as shown in your diagram. But then anyway, since it's not nodular thing, but you'll also keep lymph nodal mass as one of the different diagnoses. Yeah. Go ahead.
How will you proceed now?
Right.
So now I'll confirm the diagnosis, sir. First, I will go with an ultrasound abdomen to look for the organ of origin, sir.
Okay, keep going.
So shall I go with the report, sir?
Yes.
Ultrasound abdomen showed a thickened and edematous ileocecal junction and thickening in the cecum, sir. And there's hyperechoic fat noted and multiple adjacent mesenteric lymph nodes. Sir.
Okay. Can you plan your treatment based on Dr. Dalvi wants to come in?
Just want to ask Akhil, how reliant is the ultrasound to detect bowel pathologies?
Sir, so it's as a part of extended examination.
No. You as a surgeon,
Yes, sir.
if you palpate a mass in the right iliac fossa, would you like to, with patient colicky abdominal pain, no other symptoms, will you still rely on USG report for a bowel pathology or another investigation? That's what I want to ask.
No, sir, we won't rely on ultrasound.
Then why was it done? It's okay. It was done. It's in your institute. It was done. It's okay. Tell us.
Akhil, don't let your seniors bore you down. You think it's ultrasound is the first investigation? Say it. Tell us why it is.
And I'll ask that Shenoy that whether, as an examiner, would you insist on ultrasound to start with and why?
Definitely, sir. I think I have no doubts about it.
I think this is a discussion between examiners. Let us keep it aside. The boy has to know.
Yes,
the
you have
boy
to know why you want to get
absolutely has to know. He has done an ultrasound. Akhil, tell us the report. No problem.
Akhil, there are two questions actually.
Yes, sir.
Is ultrasound the first investigation? And in bowel pathology, is ultrasound the ideal investigation?
Sai Saab, just cool down because it demoralizes the student.
Okay, sorry.
Yeah, thank you.
Okay, what next?
Akhil, go ahead. You have done an ultrasound, you got some findings. Then you must have surely got CT scan done.
Yes, sir.
Yeah. So what does it tell you? What is your diagnosis?
Patient was admitted under the GEC, sir, for the further evaluation. Following up the lab investigations, which are within normal limits, sir.
Then you come back to hemoglobin. But when you said the patient is clinically anemic, does it hold water? And the hemoglobin, can it rule out some pathologies? Is the hemoglobin okay or low?
Okay, sir, towards lower border.
Okay, so it is possible that palpable cecal malignancy may not have this much hemoglobin.
Yes, sir.
Right? So then in retrospect, the anemia which you're talking about is sort of a relative thing. Okay, go ahead.
Patient underwent CT, sir. This is a axial view of contrast enhanced CT showing a diffuse cecal wall thickening, sir.
If you say contrast enhanced, which phase is this? Is this arterial?
The portovenous phase.
Yeah. Why?
Artery is not hyperintense, sir. And
as compared to vertebra, that is not equivalent. In other words, the intensity is not the same. This is on the vein. So it is a little late. It's beyond arterial. Okay, say. Continue.
Diffuse wall thickening noted in the cecum, sir, along with thickening noted in the appendix, sir.
Akhil, I want to ask you one question. Now, this is a patient in front of you.
Yes, sir.
Which is a better investigation, CT or colonoscopy? To be done first.
Colonoscopy.
I just want to go back to my kidney business later. But when you suspecting a right colonic malignancy, the first you have to establish diagnosis.
Yes, sir.
Then decide whether he is operable, resectable, or palliable. These are the three options in front of you as a surgeon.
Yes, sir.
So why colonoscopy was not done? It's okay. Now this is our CT. There's a huge mass that I can see right now. Go ahead.
So one more film showing appendicular thickening, sir.
Akhil, I'll answer this question. I say before going to invasive investigations, I'll
Non-invasive.
stop non-invasive investigation in the series of imaging. So even that can be an answer that can be given to Dr. Dalvi, saying that this is what I do prior to.
Even if we suspect an appendicular mass, then colonoscopy is a little bit dangerous. So CT will be ideal to do it
His
first.
diagnosis has
followed by-
never been an appendicular mass. Number one. Number two is his diagnosis revolving around malignancy.
Malignancy.
That
His diagnosis is malignancy, then
my,
colonoscopy. Yes,
yeah,
sir.
that is my thing. If his differential is appendicular mass, I will never do a
Colonoscopy.
Definitely.
Okay, Akhil, proceed.
And one diagnose appendicular mass against colonic malignancy on CT. Can somebody enlighten me on this? Patta?
Sir.
Can you enlighten me? Differentiation between appendicular lump and a colonic malignancy?
I can't, especially this image.
That is why
I
have told Chennai Kanagwell that this candidate has to be protected. I will protect him. Thank you.
Okay, sir.
Yeah, go ahead, Akhil.
So CT suggests to of diffuse thickening in the cecum and ileocecal junction, and there is a prominent thickened appendix measuring of 1.2 centimeters.
Yeah, but with this acute appendicitis, then of course colonoscopy is a dicey investigation. As you see here, acute appendicitis with involvement of ileocecal junction. Anyway, but then the radiologist did advise colonoscopic correlation. So at this juncture, what is your diagnosis, Akhil? Would you change anything? Would your priority change from malignancy to something else, or you still remain the same? In other words, in cecal malignancies, can you get appendicular swelling, appendicular thickness, or for that any other pathology? Tuberculosis of the ileocecal area, can you get an appendicular involvement, or any other disease for that matter?
So it can be a primary appendicular neoplasm, sir.
Then why should you have ileocecal junction and diffuse cecal thickening? Do you get it?
Can you try a course of antibiotics before proceeding further? As your CT shows acute appendicitis with involvement of ascending colon and ileocecal junction.
The CT patient has been started on ceftriaxone and metronidazole.
Why?
No. Do you think it's acute appendicitis just because the CT says so?
No, sir.
Then?
So patient is being managed by medical gastroenterology, sir.
No.
After CT report, as it shows acute appendicitis, they have given general surgery consultation.
No, that's not the answer. See, at this juncture, it looks inflammatory. All the while we are thinking in terms of malignancy. Malignancy has got very distinct CT features, but this is inflammatory.
Yes, sir.
Right. So when it becomes inflammatory, well, malignancy may not be a part of the story. We think of other conditions. And possibly that's the reason why they have thought of antibiotics. Okay, what did you do with this? You now convinced that this investigation is enough to think it is non-malignant and then treat accordingly, or what next?
No, sir. As there is a wall thickening, we need to rule out. So we did colonoscopy, sir.
Yeah, colonoscopy you do with a bit of a caution.
Yes, sir.
Okay.
Colonoscopy showed patulous IV valve with IC valve with the large slough covered ulcers. Cecum shows circumferential sloughed ulcers with everted margins and mild luminal narrowing. Tissue biopsy has been taken for the gene expert and acid fast bacilli and histopathological examinations.
So what does the endoscopic feature suggest? Did they rule out anything, or are they in favor of a particular thing?
So it is in favor of inflammatory pathology, sir.
Okay. But you said raised edges.
Yes, sir, but there is no proliferative growth noted, sir.
Okay.
No intraluminal growth noted.
Okay.
Akhil, can it be a amoebioma?
Yes, sir. Amoeba can also present with ulcers, sir, in ileocecal region.
Okay. Can this be inflammatory bowel disease? Ileocecal Crohn's.
Yes, sir. Crohn's can present with linear ulcers, sir.
Okay. Now, if it is a ileocecal Crohn's, would you go back to the CT, try correlate if anything much in favor of this? If you look at the CT back, now thinking that this looks like a benign pathology, is there anything before you get the histopath report? Can you think of something else in the CT which may suggest inflammatory bowel disease? If it is ileocecal Crohn's. Can any other part of the bowel can be involved?
So,
So you'd like to see that whether it is any, there are skip lesions.
Skip lesions, yes.
Okay, then you'll also think if it is tuberculosis, because you're taken the biopsies to look for tuberculosis, then also tuberculosis need necessarily be localized to one area. Then you get back to the CT. So is there any suggestions there to suggest this can be Crohn's, or is there any suggestion to say this tuberculosis now with when you combine this CT and the colonoscopy together?
So the ulcers are there, sir, which are non-specific, which can be either the tuberculosis or the Crohn's. And in CT, there are the mesenteric lymph nodes, sir, which is more towards tuberculosis, sir. There are no skip lesions noted, sir. So it is not towards Crohn's, and
yeah,
and it is so yeah.
How will omentum look like? How will omentum look like in tuberculous abdomen?
So there will be rolled up omentum.
Is there rolled up omentum?
There is no rolled up omentum.
So you should always get back to previous investigations and sort of correlate, because that can be a part of a discussion. And now you will wait for the biopsy will say it all. So what did the biopsy say?
Biopsy is inconclusive, sir. Biopsy is inconclusive, and the gene expert came negative, and AFB is negative for the tuberculosis, sir.
Okay. What next?
So then
definitely not malignancy, is it?
Yes, sir.
Definitely not malignancy.
But is it been said that there's no malignancy?
No, sir.
Yeah, it says no evidence of dysplasia.
Right. So we are dealing with inflammatory pathology, one, but there is no obstruction.
Yes, sir.
There is no
chronic
bleeding,
inflammation because there's
no anemia. Right. Because these things are important, because based on these, you're going to plan the next move. No anemia, no bleeding, no obstruction. Small bowel are not dilated. There's no other suggestion of any spread in the neighborhood. So when there's no malignancy, then you're in a bit of a fix.
Yes, sir.
What next?
So, because of persistent pain and non-relieving pain and mass abdomen and inconclusive investigations, we planned for the right hemicolon.
Mass is not reduced till date. The mass has not reduced in size.
Mass
in
is the
spite
same.
of antibiotics. In spite of antibiotics, it's not. There's no improvement, is it?
No improvement.
Right.
Okay.
So obviously now we are not given the right antibiotic, right treatment.
Now, is a right hemicolectomy acceptable in this patient? Why do you see? Because
There's no
We
obstructive
can
feature.
try diagnostic laparoscopy for diagnosis. Sir.
okay, diagnostic laparoscopy is a possibility, but right hemicolectomy is not an acceptable proposition for your diagnosis. Suppose if it is Crohn's disease, would you do a right hemicolectomy?
No, sir.
But then that is one of your different diagnoses. Why don't you do?
Sir, it will aggravate the disease. It can aggravate the disease.
So if it is now the different diagnosis, the malignancy is ruled out, right? Now you revise your diagnosis, then you say which are the primary diagnosis.
So the
Diagnosis 1, diagnosis 2, diagnosis 3.
so we have ruled out carcinoma right colon, sir.
Right.
So can I know what is the indication for right hemicolectomy in this patient? What is the plan for right hemicolectomy? What do you think?
Ma'am, main idea for right colectomy was for the definitive diagnosis.
Is
Get
that
a tissue diagnosis.
now, if you tell me that one set of biopsies were negative, then what I want to do?
We can do diagnostic laparoscopy and biopsy.
Yeah. Right. Yeah. After a course of antibiotics, whatever, you will re-image, you re-colonoscope and re-biopsy. You may get a diagnosis. Sometimes whatever tissue you may subject it to immunohistochemistry. There are so many other methods to, before you jump to surgery. Now, if it is tuberculosis, is it medically treatable?
Yes, sir, treatable.
If it's Crohn's disease, medically treatable?
Treatable, sir.
So now, which is the condition which is not medically treatable now, but the investigation you have till now? You want to do a right hemicolectomy to rule out malignancy, right?
Yes, sir.
No, but there is no any evidence till now. When the histopath clearly says there is no. Now you justify. I mean, you see, if you say that in our institution or with this limitation, this is you should justify because in this patient, right hemicolectomy is not a diagnostic modality.
Yes.
In fact, I would have accepted right hemicolectomy had there been obstruction, had there been impossible some stricture or something, then that would have been acceptable. But here, without a diagnosis, just going in, maybe.
CA level done?
One or two things,
Yes.
sir. Basically,
Yes, exactly.
Patient is does not belong to my unit or whatever, but I'm not. The issue here is inflammatory thing was never considered for the simple reason from the beginning, because it's been going on since 1 year plus significant loss of weight of 15. How many kg?
12 kg.
Number one. And
Hello, Rashakrishna, can you hear me?
Yes.
What is the carcinomembranous antigen level?
Akhil.
The normal, sir. It's 2, sir.
Okay.
Then
Can
cancer is ruled
I
out.
come in here?
Sir, one minute, sir. First is
Raj Gopal, 1 minute. This sort of discussion should not go on in a PG session. Different views will be there. PG has to understand what he has to do. Please go ahead.
Rather, sir, I would like to come here and what is the possibility or potentiality of a repeat colonoscopy? Because there have been very clear guidelines which says when to repeat a colonoscopy when you have a first biopsy inconclusive. Number one. And number two, what will be an image guided biopsy indication in this patient? Because this is a fairly big mass, whereas colonoscopy did not reveal much contribution to the mass. The interventional radiologists are keen to put in needle wherever, even in a difficult location. Can this be a consideration? Because for a teaching purpose, let us clearly indicate when is the second colonoscopy required if first colonoscopy is not giving the information. And what is the role of a needle biopsy here? What is your take on it?
My take in this patient will be a diagnostic laparoscopy. Diagnostic laparoscopy, again, it can throw light on it because we know what the surface is like, and there are some lymph nodes in that area which can be biopsied. Needle biopsy in FNAC is something which is not very ideal here, and for that matter, even a core biopsy in a luminal structure is not an acceptable thing. And again, the yield you get from the lymph nodes in the abdomen, especially in the mesentery area, actually, it's the needle biopsy or the core biopsy is not an option. When you have a diagnostic difficulty of this nature, diagnostic laparoscopy is definitely an option. Of course, even then, if you can't make out well, then there's an issue, because the thing why I want to emphasize on, I don't know, many senior examiners may agree, disagree, but when you talk about right hemicolectomy for diagnosis, it is something which is done in extreme conditions where you take out all your possible investigative modalities that are available. Because in this era, right hemicolectomy is not usually done, unless especially when imaging and a colonoscopy did not suggest a malignancy.
And what is the role of functional imaging here, sir? Will you consider an FDG here at any point of time of this patient care?
FDG can be considered, but then unfortunately, with so much of inflammation, the FDG will tell us like a huge mass. So here, since the inflammation,
the entire area will light up.
So then we'll think that we have to take the whole thing off completely. Anything colorful you see in a PET CT, you want to take it off. Logically, at the end of the day, this will give a diagnosis. There's no doubt. But again, if the diagnosis comes as something benign, which could be treated medically, then we'll cut a sorry figure. In the sense, this could have been treated medically, because I think we should exhaust some more investigative possibilities, which includes a diagnostic laparoscopy. Is my take. Coming with.
I think
and regarding the role
examiners
of,
have a very...
No, I'll tell you, regarding the role of repeat biopsies, when there's a doubt of the very high degree of doubt about a malignancy, and when you're going to do some surgical procedure, then there's a role for, like, actually there's a rectal lesion. You do clinically you think it's malignancy. You do a biopsy, it is negative. Now we have to think of now the question is, I'll give a course of metronidazole. I'll repeat the biopsy. I'm not going to say I'm going to resect and see whether it is malignancy or no malignancy. But then that's it. I mean, right colon is a stepsister to rectum, but again, surgery is a huge issue.
Fair, sir. I think we'll allow the candidate to pursue. What was done, Dr. Akhil? Please go ahead with that. Next step of what was done for this patient.
Patient underwent the right hemicolectomy, sir. Intraoperative findings were...
Don't tell that way. No, don't tell that way. You try to go ahead. Did you do a laparoscopy or you do a laparotomy? You tell about the finding, then you tell what was done.
Yes.
We did the laparotomy, sir, and multiple mesenteric lymph nodes with minimal free fluid noted in the peritoneal cavity, sir. And mass is freely mobile and thickened.
Multiple? Please go slow. Please go slow. Multiple peritoneal nodules.
No, sir. Multiple mesenteric lymph nodes.
Am I getting it right? No peritoneal nodules.
No peritoneal nodules, sir.
Okay. Can you categorize or characterize the nodules, nodes rather?
Sorry,
how
sir?
big were they? Are they discrete? Are they forming a conglomerate? Whether purulent discharge? Can you characterize something like on that lines?
There are firm in consistency and mainly pericolic, sir.
Okay.
They are not conglomerated, sir. They are discrete.
Okay.
Akhil,
So
can you
which
tell
was the
me
most
the details
medial,
of the
most
mass? Can you tell me the details of the mass that was palpated during surgery?
So mass is in the right iliac fossa of
No. About when you palpated it, I presume it is open surgery.
Yes,
Even
sir.
if laparoscopy. Did the mass?
Are is asking what was the description of the mass when you
Mass.
opened the abdomen?
That led you to do a actually radical hemicolectomy?
So the mass is firm in consistency, irregular surface, sir. And it is a mobile mass, sir.
No.
Where?
When you see the mass, when you open the abdomen, you told there was a multiple mesenteric lymph nodes, and you have written there is a mass which is freely mobile. You describe that mass.
The thickened cecum and appendix are adhered together now.
So the mass was intraluminal. Akhil, was the mass intraluminal?
Sorry, sir.
Was the mass intraluminal?
Mass is extraluminal, sir.
Extraluminal, okay.
Okay, Akhil, I'll ask you one question here. You're going to go do a right hemicolectomy. A right hemicolectomy for a benign disease is different from the right hemicolectomy for a malignant disease.
Yes,
so
sir.
you've done a right hemicolectomy for a benign disease or a right colectomy thinking it's malignant. Is there any difference between the two?
Yes, sir. Lymph node
How did you
dissection.
decide on table without a biopsy as to whether you'll go a radical thing or a non-radical excision? How did you decide?
Patta, he's a resident. Though some decisions have been taken by the HODs or the HOUs.
That's fine, sir. But I'm only thinking. I want to know his philosophy. What is his
exactly?
Logical way he's thinking, because this is him. Tomorrow he's going to do. I think next year he'll be doing.
It is important. It is important for him to explain to us, in his way as a resident, what he has understood from the surgery. So the questions have to be differently questioned. So Akhil, just tell me, you have listed intraoperative findings at multiple mesenteric lymph nodes as the first thing.
Yes,
what
sir.
is about the growth? What was talked about the growth? Tell us that.
So the growth is thickened cecum with the adhered appendix, sir, and irregular surface.
1 minute. Listen, if you have not understood what was done, don't answer. I did not understand is the best answer to give. So when the patient was opened, you realized that some discussion took place and a right extended hemicolectomy was done where there were multiple mesenteric lymph nodes, no peritoneal fluid, sent for cytology, etc., thickened cecum, etc., and isolation was done. What did you learn from it? Next time such a patient comes to you, as a qualified surgeon, will you do the same thing or no? With the details of the investigations that are in front of you in this given patient. That is what I want to know.
So with the diagnostic laparoscopy, we can get the lymph nodes or the tissue from the mass, and we can get the diagnosis, sir, without laparoscopy.
You do a diagnostic laparoscopy, you find big nodes there. Before thinking of doing resection, what will you do?
So we'll see for the peritoneal nodules, sir, and
nodules are there. Now what will you do?
So if
there is a big nice lymph node in the ileocecal region, more than 2 centimeters staring in front of you. What will you do?
Sir, I'll give you the way you wanted. Would you
do
thank you, section?
Thank you. You understood what I wanted to ask.
Would you do a frozen section is what Dr. Dalvi is coming to. Okay.
Yes, sir, we can do frozen sections, sir,
but what?
It's not. We can't rule out anything with frozen sections.
Why? Akhil, let's say it comes positive. Let's say it's come positive. Don't be negative. Let's say it comes positive. Patta, take over.
No, see, I mean, frozen section is very much a part of the armament. That's what I was asking. Actually, when Dr. Dalvis objected to my language, but it is this, what I want you to say is, on table when I can't rule out a malignancy, frozen section is always available to think whether I should do a now you do a right hemicolectomy like you do for a benign thing, and the histopath comes as malignancy. Would you go in again and do the rest of the surgery? So effectively, whenever there is a doubt about a malignancy, you do a radical thing, because when it comes to morbidity, there's not so much difference, and technicality also there's not so much difference. So here you take the help of frozen section, so always, if you get it negative, that's a different thing. But as Dr. Dalvi says, if it comes positive, what do you do?
Yes.
As a postgraduate, you should think of these possibilities that, it could be malignancy, and the best way to make it out is, nodules for biopsy during laparoscopy. And also, for example, if the laparoscopy, when you do and you take a peritoneal nodule and frozen section comes as granulomatous, would you proceed further and do a right hemicolectomy?
No, sir.
Then isn't laparoscopy a very significant mode of investigation?
Yes, sir.
So you need to give enough credence to all these before you go for I'm not criticizing a treatment protocol, because many institutions, that's one of the quickest way to get, it depends on, patient load, patient can't stay on, but that is acceptable. But all this philosophy behind the treatment that is given should be discussed, or it should be thought of by you as a postgraduate. And if you can give all these, one by one, it looks very nice, and we think that you're quite knowledgeable and thought of all those things before you took a final decision.
Akhil, in some places there's no frozen section. Then it is better to go in for a surgery for malignancy rather than just benign, because you can't come back again and then go back for surgery again, right?
Yes.
So if you don't have frozen section, you still think that you have to go in for a hemicolectomy. It's better to go in for an extended or radical.
There's a drain kept in the anastomotic site. Is it a convention you use a drain in right hemicolectomy? What does the literature say?
No, sir.
Then why did you put?
Not mandatory to place a drain, sir.
Then why did you do? You can say it's a unit protocol. Fine. What is the final? Do you have the diagnosis?
Yes, sir. This is the resected specimen, sir.
And looking at the specimen, it doesn't look like a malignancy surgery to me. Does it look like a malignant surgery to you?
No, sir. We did considering as a benign, sir.
Okay.
Even the mesentery is not visible.
Right.
Okay. What's the histopath report now? Final.
So histopath report is showing non-Hodgkin's B-cell lymphoma from cecum, sir, and neuroendocrine tumor of appendix.
Two tumors, two different
Yes,
pathology. Okay.
Two different malignancies. No wonder everything is confusing.
But in retrospect, I think for the appendix, the treatment is complete.
Yeah.
And of course,
Have they did any IHC?
Yes, ma'am. IHC was done, ma'am. CD20 is positive, and K69 is K67 is 90%, more than 90% for the lymphoma, ma'am. And synaptophysin is positive for the appendicular lump, ma'am. And K67 is 6%, ma'am.
We also did chromogranin A, IHC.
No, ma'am.
What about the nodes? You told there are multiple lymph nodes. What was the biopsy from that IHC result? HP result from the biopsy node?
Ma'am, appendicular total 16 lymph nodes were dissected, ma'am. None of them shows any signs of pathology, ma'am.
Okay.
Okay, what was done, Dr. Akhil, for this patient with dual pathology?
So
How
the
did you
follow-up, follow-up, we discussed the patient in multidisciplinary team, sir, and PET CT was suggested for the staging, sir.
Okay. Was it done?
No, sir. PET CT yet to be done.
Okay. So what do you think will be the role of PET CT here?
So the it will help in staging, and it will in non-Hodgkin's lymphoma we'll be able to know the staging, sir.
Now, regarding the neuroendocrine,
Yes.
the lymph node, if there are lymph nodes along the superior mesenteric vessels, how will we know whether they are due to neuroendocrine or due to lymphoma? Is there any method?
There is lymph node doesn't show anything. It's non-specific.
In retrospect, neuroendocrine tumors, what else would you look for?
Sorry, sir.
In retrospect, in neuroendocrine tumors, what would you look for?
So we look for the size, and we look for the lymphovascular invasion and mitosis.
Any other investigation which would have helped us?
I say there are some liver secondaries which are not seen on a CT scan in a neuroendocrine tumor of the appendix. How will I know whether they are liver secondaries which may not be seen on a CT scan, CCT?
So the
is there any other investigation which can show us that there is some neuroendocrine lesions?
Is there any specific functional image tracer which is specific for NET, Dr. Akhil?
The SPECT scan can be done, sir.
I'm talking about tracer, newer molecular tracer or radiopharmaceutical. Apart from FDG-PET, can something else be used
Specific
for
for
PET?
any.
Gallium dotatate can be used, sir.
Okay. So gallium dotatate is specific for NET. Does it be useful for lymphoma?
No, sir.
So this is going to be a difficult one. Your nuclear medicine guys should work on this, because dual tracer scans have to be spaced very much differently, because you cannot run both the scans in together in conjunction, because here you have dealing with two different pathology, and both deserves a different line of chemotherapeutic drugs, I'm sure, because the management options, were you able to remove the entire disease, say the mass nodes with the R0 resection?
So the nodes, we removed only the pericolic nodes, sir. We didn't go till principal nodes, sir.
Were there nodes
Was
at all?
that nodes enlarged?
Yes, ma'am.
So, Akhil, how will you reflect on your presentation? How many marks will you go out of 10 to yourself? And why?
Self-reflection.
Out of 10, how many will you give yourself and why?
Maybe 5 or 6.
No. Why are you giving yourself so low marks?
Be
You've got the
generous,
option.
man.
There's no constraint. Give yourself the best marks. How much would you give? Now give yourself.
So 7 or 8. Sir.
Anyway.
Yes, now he asks you why. Now you tell us why.
Why did you get the 3? What happened? Why did you when you get 10 out of 10? I think that Ganesh, we have crossed the time.
No, sir. Let us
It's a very interesting case.
Yes,
a
sir.
lot of thought-provoking thing can go on, and the only thing is that the mind should be open. When you should have there's a huge confusion when there's a malignancy or benign, and that confusion went on till the end, and but this will be a great lesson to. We all think that right iliac fossa mass is a very simple thing, technically, diagnostically, and all that stuff. But there's so much more to it. But the googly is that there are 2 diseases, strangely. So appendicular pathology is one, and the lymphoma is one. And again, obviously, when this should have treated as a malignancy and removed all the important nodes along the iliocolic, right colic, and the middle colic vessels, that'd be a wonderful thing to do. frozen section is a thing we should seriously think about when there's diagnostic difficulty. And again, you shouldn't think of doing anything invasive without a proper backup, without proper diagnosis, because that is not generally acceptable. Right hemicolectomy may not be a big procedure, might not cause morbidity, but the whole science of GI revolves around this as to, how you decide what to do and when to do. Anyway, well presented, I should say. Then
I think this whole case was an Agatha Christie novel. Right till the end.
Doug Shenna, you're looking silent all the way because it's a student.
No. Since he is a postgraduate, the level I think has gone beyond MCH level. Number one, it's good to know from the candidate what he knows rather than probably what he doesn't know. Number two, and number three, this is done by the top medical gastroenterology person who took multiple biopsies and said managed by them first, and then they said, of course, patient doesn't belong to me. That's a different issue. In our institute, some other that. So when the gastroenterologist people said everything is CT done, this done, that done, and we always talk about clinical, we should give lots of importance. It's been going on since 1 year, 12 kg weight loss. How will you think of acute appendicitis? Just because the CT said acute appendicitis thickening. So there's no point in thinking of inflammatory in the sense no diarrhea, no blood, no mucus, nothing. So how will you think of Crohn's disease or ulcerative colitis in this patient? These are my thoughts. Patient is going on since 1 year. So medical gastroenterology decided that endoscopy done, everything is investigation is over. Then what next? Okay, suppose you had done a repeat colonoscopy, you had done negative, what you would have done? So obviously you have to proceed without a diagnosis. I know that today it's very important that you have done all the possible tests and then we are helpless. So yes, diagnostic laparoscopy, frozen section, undoubtedly probably 2 other modalities. And then the rest, of course, that's why these are surprises. Surprises do happen. So in spite of all the investigations.
Sir, one question. Was the mucosa appearing normal in colonoscopy? I missed that part.
No,
Ulcerated, sir. Sloughed and ulcerated.
Okay. So in that case, otherwise, depending upon the thickness of wall, we can think of lymphoma as we think in stomach. And then we can, if possible, we can take some biopsy theoretically, but provided the mucosa is normal.
They have taken multiple biopsies, sir, and that
not from the way Kanagwell sir was asking, image guided from outside. The way we take sometimes in lymphoma stomach.
Sir, Hitesh sir, I would be putting the word in caution because taking a biopsy, especially in these
I understand,
cases,
sir.
For it is for us as a consultant level, we can keep debating. But then the radiologists are now doing guided biopsies for leiomyoma, stromal tumors, or whatnot. Their needles are very fine. Even they get 26 gauge FNA or FNA-B is possible. So on that lines, okay, sir. But I think the KMC team has very appropriately managed, considering the 1 year plus. We have to give a solution to the patient ultimately.
Of course,
but,
of course.
I would also say, sir, it is all lesson for us. But for the students, I would say candidate, if they say a right iliac fossa mass, many times they end up discussing either as a malignancy or ileocecal tuberculosis, and they are asked questions on that track. Because they presented the CT scan, pathology, all those things, then I think we are able to take it further. But one word of thing, I would request Akhil to go back to the radiologist, talk about to reassess the films, revisit the films, because as Patta sir said, the inflammation of the appendix only confused all of us. If they very categorically note non-inflammatory thickening of appendix, or they have to revisit definitely, because they have done a contrast, they have done complementary imagings. So it is lesson for them also to revisit. So in future, I'm sure I have hardly seen 6 lymphomas of the colon. Maybe seniors here would have seen more lymphomas of the colon. And many times my patients, whomever has come with bleedings or obstructions. So I had no confusion or no limitation in making a decision of a resection. But I'm sure people can rise up to say non-obstructed tumor, non-anemic. In fact, Patta sir was raising brows when you tell hemoglobin was just okay.
Yes,
and
yes.
CA was normal, because I remember he insisting on that.
Yes, sir.
So are we dealing with something else? That was the question from the beginning. So I'm
Yes, sir.
sure as a postgraduate, for you, it is worthwhile you go back, read Devita about the entire lymphoma, because Devita gives a very good thing. And then you go back to the NCCN, because NCCN guidelines for lymphoma have now been extended as a separate NCCN lymphoma guidelines. So go back, there are enough material for you to read up on that. And you should also know here how much should be the space of FTG PET. First, what is the role of DOTA? But again, radiologists may come back to say, sir, let us do a FTG PET first. And if it is not conclusive, go for DOTA. Right?
Yes, sir.
And one more thing, you should go back to your pathology and ask for chromogranin levels. That is the most important thing, because they also, when they have picked up 16 nodes, it is much more than pericolic clearance. 16 nodes is fair enough, a good clearance to track about the root of the, I would say, origin of the vessel. So with 16 nodes, as madam was repeatedly asking, IHC with chromogranin, IHC with, I think, lymphoma they would have done for the entire panel, will help us to understand. But please be aware, the pattern of spread neuroendocrine tumor is different, pattern of spread of lymphoma is different. So it is, you have to go back and take back your textbooks, read about everything so that you have a clarity on this. Maybe that is from my side. Other faculty, Rajgopal sir, would you like to give your final thoughts?
No, sir, nothing, sir. What I'm trying to tell is that say diagnostic difficulty was there in this patient.
Perfect,
so
perfect.
Presentation is fine, and probably the whatever the few things which are missing were diagnostic laparoscopy probably and the frozen section. So some logistics are there, that what time the case was taken to the operation theater and what time that decision was done, and then the pathologist availability and all those things are there. So few things, right? Of course, these are the
One good thing is, even if it was done, probably we would have missed that appendicular pathology. So whatever has happened for the better
Good
thing.
for the patient.
Take it positively. Yes.
I think can I say this discussion should be taken in an academic point of view.
Yes, yes.
There's no
Yes,
fault finding that this is done, this is not done. See, the whole idea of a postgraduate clinic is just to analyze each step that's being done, because all of us do many things which don't fit into a convention.
Of course.
The final thing is the patient is doing well. That's what it matters. But science has evolved in a different way. So the logistics which the student is thinking is what is questioned. I mean, it's nothing to do with the unit which is treated or the method it is done. I mean, that we do many things. We don't do also many things. So that shouldn't be a part of the story. The story is that whether the student is thinking in the right way or not.
Fine. I think
To be frank, this is a case for presentation in a CM or like that,
CPC,
rather than
CPC.
PG exam. Yes. Yes.
Sir,
Yes.
Rajgopal sir wanted to keep it like confidential, because this makes the discussion appropriate. So I think the candidate was up to above the standards of taking till the management level. Maybe the candidate should be reading back what is the standard right hemicolectomy, what is complete mesocolic excision, what is the role of medial to lateral dissection, lateral to medial dissection. As Radha sir said, how radical is radical. These are the things as a PG you should be aware of. Don't worry about the decisions. The decisions are always done by your chiefs and you have the cover of them. And when there are challenges between chiefs, I think the winner is the patient. Patient should be getting the best of it. So you go back to read all those limited areas where examiners will be particularly asking about it. And little bit of follow-up of this patient should also be aware, because the follow-up guidelines are very clearly telling different thing for NET and different thing for lymphoma, right? So you also should find out what happens when there is a combined disease and which prognostication is to be used. For the NET prognostication, obviously it is excellent. But for lymphoma prognostication, when there is an existence of NET, you should go back and refer the literature, which I will do tonight itself, because definitely those things are the one lessons to be learned, because the patient will come back to ask you, sir, am I done with my treatment? What am I pending with?
So that is our responsibility now, as MDT has decided, or even you can have a follow-up MDT with all the concerned specialists. Then you should appropriately advise regarding the follow-up. This patient may need more frequent follow-up or more longer follow-up considering the dual malignancy. He comes under high risk category, whatever it is, if it is a dual malignancy. This is my thought, sir. Any other faculty, Babita ma'am or others would like to share something?
No, sir. I think we have done elaborately in this patient.
Akhil,
From
do you have
starting from
questions?
benign to the malignant, and the candidate was also able to discuss his thoughts very well, except for a few things like the indications for right hemicolectomy and on the clinical examination on palpation, certain things, and he has to add certain things to rule out the other differential diagnosis in history. That's all. Otherwise, he has done well.
Perfect, ma'am. Perfect. Akhil, would you like to ask any doubts? You would have now, after going through all these things, do you have any thoughts to be clarified with the examiners? You're tired.
So, as it's neuroendocrine is in the pathology, it is showing 1.3 centimeters, and there are no lymph nodes, and CT is not showing any signs of metastasis. And after the opening, also there are no signs of metastasis. Still, should we consider any further as a hemicolectomy will be considered adequate for the neuroendocrine tumor of this size? No?
I think Radha sir, you take this question.
See, actually, technically, 2 centimeter, less than 2 centimeter, whatever treatment done is good enough, But here, the reason why we need to follow up is that if you really talk in terms of surgery for malignancy, whether it is neuroendocrine appendix or cecal malignancy, there is the amount of tissue that is removed, especially the mesentery part of it, is a lot more than what is done here. The 16 lymph nodes are pericolic ones. We have not come to the ileocolic or right colic nodes, which can harbor some metastasis from neuroendocrine tumor. But having said that, the whatever surgery done for this appendicular pathology is good enough, complete enough. But still, I would like to follow, because we've not really done the nodal clearance which we do for any malignancy in that right ileocecal area. We have operated as though we operated on a benign condition. You agree with me?
Yes, sir.
I think Dinesh sir has left, I think, sir. Dinesh sir was also here. I think he left some time back. With the permission of the faculty, I think we have extended the time, but for the sake of the case, I think it is worthwhile discussing. Thank you, Radha sir, for joining in such a short notice. Because I knew the case, I wanted to pull you up. So that, I think it was a combined learning. Rajgopal sir said yesterday that he has confirmed the case, and then moment he said something is more in cooking rather than a straightforward case. That's the reason we called you up. And of course, I kept it off the records to you so that you come unbiased. But you were in between. I was very sure that you're going to pick up something else. But then the candidate was dragging on to the different
direction. We run DNB GA surgery, so I always think anybody has that sort of candidate. Sorry, because as Dr. Adali was upset that the questions are beyond what MS general surgery, and Dr. Shanna is also quite upset that post MCH level. But it's all quite interesting. People should just have a feel.
No. I'm not upset. Not that way. Definitely the discussions are good, but the thing is, I only mentioned that questions of that level it has gone. That's what I said.
The boy is tackled well. He didn't bow down. He's tackled well. I hope.
Acquiring any amount of knowledge is wonderful for a postgraduate, sir. Whether it's a
good thing is he never jumped to lymphoma at all.
Yes.
It is very difficult to constrain. He has never thought put a differential diagnosis rare, even after Paro findings. That was the good part.
True. I think that's appreciable.
Yes, sir.
I think all good things have to come to an end. And I thank Babita ma'am, Radha sir, Rajgopal sir, Hitesh sir, and I think many have already left. And thanks Akhil and for undergoing all these onslaughts. But then there are lessons. You quickly make note of it in your hand note and get back to the library or whatever electronic source you have. go back and refresh your knowledge if you have not read some areas. Lymphoma will be an exam question for sure. Either in short note or long question, you will be asked, or in Viva, you will be discussed. So lymphoma, you should be thorough. Nodal or organ-based, solid organ-based, luminal lymphomas have to be. Lot of exciting things are happening in lymphoma. As Pata sir from the beginning was telling, conserve the luminal organ. In spite of, unless it is going to have an obstructive or bleed or perforation, nothing else can be a reason for a surgical removal of any lymphomatous organ, because the modern chemotherapy can effectively handle the lymphoma well. So I would request you to go back to the basics first, then you go for the NCCN guideline. Because if you go for NCCN guideline, then it becomes truly, you become application oriented. So please understand where exactly lymphoma begins in the luminal organ, in the solid organ, in the lymph node. There is a totally different fascinating area of biology which happens in lymphoma. It is worthwhile spending a couple of days reading about lymphoma. So much of material are there. It is definitely, you will come across, at least we do come across in every department, more commonly along with tuberculosis, you get to see lymphoma. Lymphoma is no more a rare diagnosis. So it is prudent, you are well updated. I think with that, we call the session the close with the permission of the faculty. I thank the students for joining us and staying back with us. And we look forward to meet coming Friday. Thank you, everyone. Good night, sir. Good night, Akhil. And I also thank Dr. Karthi for joining. I think he has left. Thanks, Karthi, sir. Andariya, sir, thank you very much. Good night,
Thank you, sir.
Thank you, sir.
It was
Thank you,
learning for
sir.
us as well.
Good night, sir. Good night, everyone.